Um, Thanks, Chris. I heard that. I'll give a little bit about myself and where I'm at. My name's Dan. You can call me that in the chat, or if you want to come off mute. I am a pediatric gastroenterologist here in Madison, Wisconsin. I'm the division chief, so I'm in charge of the group here in Madison. And I am an IBD doctor. I'm a pediatric IBD doctor, and I'm a faculty member at the University of Wisconsin-Madison. Um, let's see, we take care as a center of about 150 individuals with IBD. And I work closely with the whole team, my nurses, my nurse practitioners, dietitians, to help take care of people. All right. And I chose this because it's kind of sticky. And these navigating as a parent or caregiver of a teen or young adult with IBD, and wanted to talk about things that I see in clinic that often get left to at the end of the visit. And how can we talk about these important things and maybe the intersection of the things that you guys are dealing with as parents with children with IBD, that maybe I can help you plan a little bit better, be better informed, ask well-informed questions. As Chris, I'm a doctor. I'm happy to, field general questions. I think if there's a lot of specific questions around specific circumstances, we can take it offline or direct you back to the team. But I hope this really helps set the stage for some of these conversations. All right, let's see if I can advance. All right. I relied on the caregiver coping resource. As like the pictures there are great. I know members of this team really worked hard on that, and it can be a really nice resource. But my opening is that this is a lot, and there's a lot of topics we could cover, um, and some of these topics may be more relevant to some than others, or people are at different stages in their the patient, your child's um, kind of physical and emotional growth. But hopefully, like I said, this serves as some background information. This is also permission for you to ask your care team, your doctor, your APP, your nurses. We expect these types of questions. These are safe spaces. Hopefully, you all feel comfortable asking questions. And sometimes actually saying out loud is harder than if you write it down. And sometimes somebody has a list, and I'm like, oh, what else do you got going on that list? And that's a good way to keep up your nerve if you have something that you feel like maybe more sensitive, or may not fit the usual pattern that we all develop. And as doctors, I'll just say sometimes your doctor may not want to talk about this, or they may be awkward talking about it. Your primary care doctor may be more, I don't know, rehearsed to talk about things like growth, development, sexual health, menstruation, smoking, alcohol. But your IBD doctor should be able to help you as well, put things in context with expertise that you may not be able to get from your primary care doctor. So again, this is permission to ask and recognize that if you don't ask, we may not know what's going on inside you or your child's head. So there's also there's a growing model of scientific work around this. I won't go into big details around this, but I'll use some references here more for my connection to the data and remind myself, and also for any docs, APPs, or other people on the call that want to go back and look at some of the data. There's evolving models about taking care of teens and young adults. Some of the scientific framework isn't very practical for families. I just want to acknowledge that there may be a lens, like a more research or scientific lens to some of this information that's out there, and how can we kind of distill it into something practical. And I know there's a lot of work going on with transitions, right? This is teens and young adults are moving from systems of pediatric modeled care to more adult modeled care. And there's a lot of work going on there. This is going to not focus on that. But that is a big part of taking care of teens and young adults. I wanted to kind of narrow it and be more specific so that we could get into some more details. We're just going to jump in. I kind of separated this into like, the sex, drugs, and rock and roll kind of talk. If anybody knows Marla Dubinsky, she's like a clinician out at Sinai now in New York City. She gives a great talk. She was a plenary speaker at ICN a couple years ago. Um, and I modeled some of my presentation on things that she had said in the past as well. Um, so I'm just gonna get going. Put things in the chat. If it's really busy, I may miss something, so maybe I'll rely on people to kind of boost that up to get back into my into my field. But I wanted to just start, and we're just gonna start with alcohol. It's a reality of teen life. Looking at the data that's estimated to be on par with non-IBD peers, meaning like people with IBD are using or experimenting with alcohol at the same rate as their peers. Um, Specifically, though, alcohol can affect patients with IBD in very specific ways. The bugs in our intestine are affected by alcohol, mainly some of like the sugars, and because alcohol is a sugar, and how does that feed good or bad bacteria? It can disrupt that gut barrier and increase permeability or how things pass from the tubes of our intestine into our bloodstream, and it can indirectly promote immune activation. So the thought is that alcohol consumption does this to anyone, but those with underlying inflammation, whether or at risk for inflammation, even when their disease is under control, it adds a particular risk in patients with IBD. Like it can make you feel bad. If anybody's ever, the adults on this call have used alcohol, understand this. And it can increase GI symptoms that can sometimes, especially for young people, be hard to figure out. Is it related to alcohol consumption or is it active disease? Um, I know when I talk with my patients who are learning their bodies, especially those who are newly diagnosed with IBD, you may not know what's normal, what feels good, like what's your new norm, I guess you may not be able to really tell the fine details between those signals that your body tells you. So alcohol can affect this and other drugs too. And I think that's part of the process of like growing up, whether you're a young person, like a school age or later. We learn, it takes a while
It's
to
okay. I
learn.
skip my bag.
Um, there's particular medication interactions that I think are important just to highlight that you can bring up with your team. There can be increased liver toxicity or effects with some of the medications we use. We use a lot more methotrexate now in patients who have IBD, particularly as um, in patients who are on adalimumab, right? The Humira and biosimilars. There's new research that suggests combining methotrexate with those shots may increase the effectiveness of the biologic. So more and more patients may be having this. Azathioprine is an older medication. Most people aren't using this a lot in their practices, so maybe not as typical. But you don't want to drink with it with particularly methotrexate. It can have this interaction with metronidazole, which is often used in like infections, perianal disease, Crohn's disease. Man, it can make you feel bad. Um, so it can give you this disulfiram-like reaction. That's the medical term for getting nauseous and vomiting when you interact metronidazole or flagyl with alcohol. It's usually like really kind of quick. And so in patients who are on that medication, they could have really significant side effects and important just to point out. It can make you dehydrated, and that can affect GI symptoms and may affect some kind of general body, kind of general symptoms. And then I'll reference this again. It's the basics. And as Heidi mentioned, these are things that these are topics that you're introducing to your family over time and kids based on their developmental readiness for it. Um, and I think what I stress for folks is that there's really just the basics around safety when using alcohol, both personal safety, being aware of your surroundings, um, uh, and then driving. So, again, when you frame it, it's not, I think it's important to talk about those big picture risks as well as maybe highlight some of the specific risks that you learn from your team or that you find from trusted resources like ICN, Crohn's and Colitis Foundation, etc. All right. I'm going to move through some of these topics. So, when I think about smoking and nicotine, I think things have really changed. I don't like know everybody's age on the call, but like there were not like vaping and pouches and other ways to get nicotine are very different nowadays, and teens are using them differently and young adults. And so most of the data we have, like if I put on my scientific hat, is related to cigarette smoking. But we know cigarette smoking in general is lower in teens right now, and young adults than compared to other sources of nicotine delivery, like vaping, pouches, uh, lollipops, you name it. So there's like a very well-known association between cigarette smoking and Crohn's disease, leading to much worse outcomes. That is a no-brainer. Like it doubles the risk of surgery, triples the risk of recurrence after resection in Crohn's disease. Um, that is an easy science-based thing. No, what actually is not is that cigarette smoking and ulcerative colitis is actually pretty controversial because historically we thought it may be protective, meaning that it improves outcomes. Um, people can find this. Like you Google it, you put it into your AI chatbot, it may tell you this. So I don't want to ignore the fact that um, the data may suggest that it's protective in UC, but that's not the reason to smoke. I think we all recognize that. But I just want to highlight that um, because there's a whole host of reasons why smoking is bad. I won't go into that. The other products, right? Vaping and pouches are kind of new for us. And I'm trying to figure out how to talk about these in my practice because there isn't a lot of science to back it up, specifically in teens or young adults or even older adults in IBD. I think one of the things we know is that vaping is highly variable in the content of what gets delivered. Yes, there's nicotine, and some of them are like super high concentrations. Some of them are low concentration. But there's just high variability, especially things that are like bought in vape shops that are like kind of sketchy. Um, and so those have a lot of unknowns and in general should be avoided. And but when it comes particularly for IBD, it's hard to quantify. Pouches the same. These are newer products. I think there's rapidly growing use. I was looking at some of the data on this week preparing, and the amount of teens experimenting with these Zyn or other brands are pretty high. So important to talk about. Um, Specifically, how does it interact with IBD? Nicotine constricts your blood vessels. That's how that's how people get effects. And it's a potent blood vessel constrictor, so it can decrease blood flow to the gut, and in theory, could worsen GI symptoms or even affect gut healing. Like I said, a bit controversial about the science behind it, but I think we can understand that not but something you want your teens may be experimenting with. All right, next up is cannabis. Um, a lot of people use cannabis. This is a study that I didn't put the reference here, but 30 to 40%, this is from a couple years ago, of teen IBD patients report use. 9% can used daily, that's pretty old. There's been legalization in areas, easier access since this data was done. So one can presume it's maybe higher. 70% report using in the past or currently. So that's of 18 to 21-year-olds with IBD. Again, a bit old, but most kids have, and young adults in this particular study, have reported using cannabis. One report showed earlier use in IBD compared with non-IBD patients. I'll talk a little bit about this. Like maybe there's a reason as we think about maybe the kind of use for GI symptoms abatement or improvement. But you can see in this data, it showed about 15-year-olds with IBD compared to closer to 19 to 20-year-olds in non-IBD patients on average. And no one talks about this with their GI doc. At least, this data said 70% did not discuss this with their gastroenterologist. We probably don't do a good job asking either. And I think as we think about effects both on like whole person care, mood, sleep, work and school, and then how can it affect symptoms and possible disease progression. The edibles and IBD, I'm interested. I'll talk a little bit about the different ways we deliver cannabis, and how that may affect some of the data too, because these are new delivery mechanisms, and the access to things like edibles and vape cartridges are much different than when this data was studied. There's a big gap there for docs and researchers to think about. How does it help? Does it help with symptoms? The short answer is yes, for the most part. It can help symptoms. It usually does not eliminate it, but uh, most described like moderate use could be helpful. I don't like how that's phrased. I'll fix this slide but I would say many people describe that it helps their digestive symptoms. But it really only affects symptoms. It does not affect disease activity. And I think this is where we can coach our young people who use this, who talk about some of the benefits. Like I'm always like, good. I'm like, well, not particularly with cannabis, but I will say, like, I want people to feel good, but your doctor also wants their disease to be well controlled based on blood testing, stool studies, imaging, scopes, right? We always try to treat to that target of mucosal healing because we know that's going to decrease people's risk of things like surgery or other complications. This is really what I would hammer home is that symptom improvement does not mean disease control. And there may be this halo effect with improved symptoms, but continued inflammation and disease progression. So it's important for our patients to get disease monitoring, routine things like labs, stool studies, which I know are hard to collect, but probably the best non-invasive test, right? And your doctors, your team will be worried that even if people feel good and there's active inflammation, it could lead to long-term complications. And so it's acknowledging this could help with symptoms, but knowing that that is not the only thing that's important in IBD care. So let's just think about that when in our clinic rooms or in the homes when where you're talking to your family. And there's some early data to say that cannabis use can increase the risk of surgery. And I'll talk about that here, about why that is. Briefly, there's really not many medication side effects or interactions with cannabis. Maybe the older medicine, the azathioprine, it could affect it. But it's not a primary concern of mine or I think your team's. Heavy use, right? It's bad for developing teens' brains. And we know it can impair executive function, kind of like those important high-level decision making, school and work performance, right? And that can directly correlate with poor medication adherence. people don't take their medicines as regularly. And I think that is one of the connections between cannabis use, maybe not directly related to worsening disease, but like what are the other impacts of the use, and how could that are important to take. I think the key research takeaway here is that large cohort studies, so big groups, hundreds of patients, show cannabis users have higher rates of surgeries and complications. And we think it's due to that halo effect where people feel fine, but their disease is active. And they delay escalation of more evidence-based therapies. So what does that mean? It means like you may not be motivated to make the appointments or drop off the stool studies or schedule that follow-up endoscopy. And so if we aren't doing those routine kind of things to look at disease activity, we may miss it. And that's a concern that could be progression. Right? Common sense, driving safety, law implications. Those are the things that you're probably thinking about talking with your teens and young adults in general. And then I have in here vaping cartridges and edibles. Man, it's so highly variable. Um, if anybody's ever heard of cannabis hyperemesis syndrome, that is like a different GI condition that can be heavy chronic daily cannabis users. We see a lot of it in our non-IBD patients in our practices, and it's really related to high THC components of in kind of variability with some of these non, I don't know, like it's not the plant people are smoking. It's usually some derivative that's extracted and concentrated and delivered in various different formats. So, um, when I think that's the big thing, Lindsay, that I see in your comment is like to think about the dose. Sometimes it's more precise, to be honest, if you look at like edibles and gummies and you're at dispensaries in New York, but there's just a lot of variability. And many times people experiment with these things without like seeing the packaging or buying it themselves. And so that dose is difficult to control with edibles. It's a little bit different with smoking. So that would be kind of the difference between those. And I would like I would I would do some of the coaching about really use caution and then common sense like around safety. Um, all right. I'm gonna move on to some of the reproductive health stuff. I know I'm like, and then I want to leave plenty of time for questions. So we'll do this behavioral health stuff and some other young adult stuff, and then I don't know. I hope people can um, ask questions. All right. So I kind of separated it into 5 buckets. I'll go through each of these buckets. Um, I think it's important. Well, I'll go back here. I think this is important. I know my patients, whether parents are thinking about this in clinic, whether they are the very early IBD patients who are having surgeries, they're not thinking about their child's sexual health, but they're thinking about their life in general. What does life look like when they're my age, right? When they want to have kids of their own. And there's like some loss and grieving there maybe at those times of really significant kind of churn for you all. And so I would say it's the first like it's okay to think about it, ask questions about it, think big picture. Um, and so um there's some good information out there around this, and I want to make sure it isn't hidden. And otherwise, people are going to find bad information elsewhere too. All right, so birth control. I'll start there. This is mostly for women. I do have a section on male reproductive health at the end. Um, but birth control, the traditional way I think about with oral contraceptive birth control, right? The hormone stuff, there's a really high risk of blood clots and combined with IBD because the estrogens in these oral birth controls increase the risk, and inflammation increases risk of blood clots. And when you combine those, they can have a multiplying effect of this risk. Traditionally, we think of these as blood clots like DVTs, like leg clots in your arms. Um, they can be and that can cause pain and swelling. In sick patients, that those clots can cause kind of clots to move to the lungs, particularly those who are hospitalized. So if you're in the hospital, it's important to talk about this risk in particular. Um, the oral pills don't work that well either. Like they don't get absorbed that as typically with patients with IBD, especially if they've had inflammation, prior surgery. They just don't work as well. They don't work well when they interact with things like antibiotics or other medications, and so you just want to be thoughtful about that. Um, patient like long-acting reversible contraception is preferred. Again, I'll talk a little bit about like are people why people are using these, but you'll hear your doctor and your OBGYNs or primary docs, adolescent docs talk about these options, like implantable options, the Nexplanon's the thing that goes underneath the arm. It's good for like 5 years and it works great. And it's pretty, and it does not have those estrogens that increase risk of blood clots. IUDs are implantable in the uterus. It's a procedure. It's not very pleasant, but but it does give really good long-acting birth control. Some are hormonal, some are not. Like those are options to talk with your doc. Depot shots, old school, like get a shot every 3 months, work pretty well too. They don't have the same type of side effects as far as blood clots, but they have other side effects. Weight gain in particular, no one wants that. So there's other better options than the depot shot, typically. Um, not everybody uses birth control because they're sexually active and want to prevent pregnancy. I think that's important to recognize. And I don't think your doctor sees this all the time. Like I don't think there's any assumptions made, or hopefully not, about why people are on these. But there may be better options than birth control if people are, or than these oral pills if people have acne, like, or they're using it because they have dysmenorrhea, painful periods, heavy periods. There may be other options that you should talk with folks about besides the oral contraception pills. Um, and menstruation in general, maybe I should have had this first, was like it can be widely affected by IBD, especially in early teens. And so progress through puberty can be delayed with active IBD. I've had patients who come to me because they have minimal digestive symptoms, but they just weren't growing or maturing, kind of progressing through puberty as expected. And so it's much more common in Crohn's than it is in UC. And they could be late onset of the first period or changes in frequency of periods is pretty common. And disease control and inflammation is really the key to normal menstruation. And your team may ask you about menstruations, last normal periods, because that's usually a marker that the body's healthy enough to do that. And that's always a good sign. It can take a while for like normal menstruation to resume, if things were really kind of typical and you could very schedulable in some ways, that can change with inflammation and may take a while to reset, even when the disease is well controlled. Heavy bleeding can worsen anemia, and we know that anemia is a key symptom in IBD and can influence things like can influence sleep, energy, fatigue, and even exercise tolerance. And so we want to just be mindful of that can be multiplier effect, especially in patients who have heavy bleeding. And so that may be an indication to just be more aggressive talking with your team. NSAIDs like work when it comes to cramps. Tylenol doesn't really do it, but most people with IBD get told they should not use NSAID. So that's like non-steroidal meds, classic being ibuprofen. Motrin, right? Advil. Um, and so you should really avoid that use. And so, what are other techniques you can use to help with menstruation? Um, kind of mitigation, whether it's heat pads or other things. And so, if you really need NSAIDs, I would talk with your IBD team about that. Period flares, increase like just all the hormonal changes that go along with normal cycles can increase gut motility, meaning things are faster. You may have diarrhea, you may have more cramps. And especially in young people who are still learning their body, who are still learning the difference between constipation, reflux, period cramps, their own flare. It can take some coaching from you all to help them try to piece that out, what their body's telling them, and try to connect the dots of those common things that happen in everyone and how that relates to their IBD. But periods, particularly around a couple days prior to their the start of bleeding, may be tough. All right, PCPs are often the ones to manage this, to be honest. Don't be mad if your doctor says like your GI is like, oh, I really encourage you to talk to your primary. Part of it is like we just don't have necessarily the infrastructure to take care of these meds, to do the refills. Most of us got trained in it, but we're not doing it every day. Like pediatricians, family docs are doing it. So usually those are the best people, but your doctor will probably be like, oh, you should really talk with your primary. They're probably better served anyway. It's not us turfing it, but us trying to just be practical to get you to the expert. And then your primary may send you to somebody else, but usually that's the first person to start with. All right, sexual function, talking a lot. Important to think about. Maybe not in our young patients, but it is like a reality of being human. And I think as parents kind of juggle that when's the right time to introduce these topics in a way that we can control the narrative, right? As opposed to others or the internet, social media. But just some facts. 50% of IBD patients feel the disease negatively affects their sexual relationships. Tends to affect male or females more than males. And body image it may be a driver along with disease activity. So that means like prior surgeries, ostomies, ceton placements, physical signs of disease. Um, or maybe it's about mood, fatigue, um, and weight, digestive symptoms that go along with the disease activity that may be prompting some of that sexual function decrease. Fertility. All right. Fertility is generally preserved in males and females with IBD. That's kind of the top line. I get asked this a lot, or I feel like people skirt around asking this. And but that is in general what I tell people. And we know that, but there's caveats here. And that active disease is a major concern for fertility and a successful pregnancy. Like we have to control the disease. And that is like if you have a young adult who's purposely trying to get pregnant, and the usually the adult gastroenterologists are managing these patients because there are experts in kind of managing pregnancy with IBD. So you may see your peds GI doctor asking you to like this may be a good opportunity to transition to an adult GI who has expertise in taking care of young people who are in that stage of life. But they'll always tell you controlling the disease. It's not really about the medications. It's all about the disease control, which almost always takes meds. Um, there's a caveat here for total colectomy with pouch formation is associated with decreased fertility. You may see this word fecundity, which is a confusing word, but it has to do with the ability to get pregnant through natural ways, through like, intercourse, as opposed to fertility that with reproductive technologies, um, you know, can be kind of augmented, different, improved. So just in general, like a pouch there's a lot of scar tissue and it affects the fallopian tubes. And so, like, the way the egg gets through the fallopian tube to the uterus and where insemination happens, like where fertilization happens, gets affected because of the scar tissue. And so that's what decreases, for the most part, people's fertility. Reproductive technologies are very helpful. Those are limited by cost and access to that kind of stuff. But we know in patients who do have access to those, these young adults who are trying to get pregnant, that they generally have very good success if their disease is well controlled. Important to bring up, though, with your doctor if you have a girl who's undergoing a total colectomy and pouch formation. Meds are always a concern. No one wants side effects, right? And I think it's right to ask these types of questions. Um, and in general, the our medications are pretty safe. Methotrexate, like I said, should be avoided though. And it should be stopped prior to conception. Your doc may want to talk about being on birth control if there's a potential for pregnancy, um, particularly with methotrexate. That can be reversed with stopping. So some of like the will it affect long-term outcomes? Much less likely. It's about the short-term, real-time kind of problems. Biologics, most of our patients are on biologics, to be honest, or many of them are, especially if they have Crohn's. It's important to have really good disease control, and biologics are safe. There's a really cool long term. Finally, like 10 years ago, somebody was like, we need to take women with IBD seriously, and created this big registry looking at outcomes of people, outcomes of pregnancies, both the moms and babies, because both that dyad's really important to look at risk. And so we have like good evidence now. And that study is ongoing because we have lots of new meds. And so in general, we found that there was no increased risk of infection in newborns or birth defects. The caveat here is avoid live vaccines in infants in the first 6 months of life, except this like one medicine, which is like a little bit different, but not many of our patients are on this uh, certolizumab or Cimzia. So what does that mean practically? Avoid rotavirus vaccine. At least that's the general principles with biologics in infants. JAK inhibitors, like particularly Rinvoq, right? Like you may have heard of these, you see commercials for them. And those are more common in peds. I'll talk a little bit about meds in just a minute, like a little bit later, but you shouldn't use it in pregnancy. Very high doses can be problematic. But there's been more recent data looking at Rinvoq and people who were on it at the time of conception. And because the concern is like really early on, there can be effects with like the fetal development, but there were no adverse events. Some of this mouse data was like from these super high doses that you wouldn't expect humans to be exposed to with like routine dosing. So that's one of the caveats when you look at some of this. But the best practice is like our patients who are on this who can get pregnant shouldn't get pregnant. And they should have access to those long-term birth control options um, like the implantables. I don't have many patients on this ozanimod, but it does exist for adults with UC and it has a similar concern. I just wanted to mention it. Male patients, big picture effects on fertility and birth outcomes are minimal to none. So active disease can impair fertility though, just like in general, just like with any chronic disease. And so having good disease control is good. And so um, there's some thought that some of these sulfasalazine, mesalamine, these are like the oral pills usually used in UC, that could have some effect on sperm motility, so how they swim. But otherwise, really it's about like being in good health overall is the important thing when considering pregnancy or considering the male partner in pregnancy. All right. I'll stop talking about that. I'll transition to mental health, and then we'll start to finish up. Um, I heard Heidi talk about this, right? It's really important. And teens and young adults have a ton of stressors that I feel like my life, if I had Facebook when I was in high school, would have been weird, different. Um, and so I think we recognize that. And there's an increased risk of depression and anxiety, and it's worse with active disease. Um, some data from last year out of Seattle looked at like, you know, 15 to 20% of patients with IBD, teens specifically, have anxiety and or depression, and that some studies show up to 50%, particularly those whose disease is not well controlled or just got diagnosed, like those with flares and hospitalizations. So I think we need to ask about it, talk about it, and treat it. Um, so your primary care doctor may be a good first step. They may have connections with community help when it comes to counselors, psychologists, medications that could be helpful. And then your center may have some specialized people to help with this. And I'll just list some terms that and these folks have different types of training. So, like a pediatric GI health psychologist is awesome if you have access to it. But I can tell you, I work with teams of all sorts of different types of setups that not everybody has access to this type of person. But you should ask, and they may. Maybe it's telehealth, maybe it's in person. There's different models for this. A general health psychologist can also be great. A general psychologist, or maybe it's a social worker who has specialized training in kids and young adults to deal with these types of things. The health psychologist has a different type of training where it's like that intersection between your medical diagnosis and your mental health. They can help tie the connection a bit better than, let's say, a community psychologist who has more generalized training. Both can be helpful, and so I think it's just a matter of what's available. I can tell you that ICN has really taken depression screening in particular. It's evidence-based and they take it seriously. We recently put it into our model care guidelines to assess this at least yearly. So hopefully you're seeing some form of this at your centers too. I wanted to put that there to kind of highlight that we get it, or we're trying to, and instill that in some of our care guidelines. And then like there's like transition towards independence, right? Like the transition work, which I didn't highlight. That's a whole talk on its own. But we really need like some of it's the mindset of like that caregiver as more of a consultant, because I hope you're still involved in a lot of the decisions, but you're not necessarily the manager of these young adults. Um, and I think it's really important for young people to understand their disease, identify red flags and flare identification, and help with medication management. That's going to set them up for success. It can be a burden though, like daily pills, injections, calendaring, right? Like setting reminders that the people will listen to. Refill management, infusion scheduling, making doctor's appointments. These are things that are going to be important for that transition work and key for taking care of teens and young adults and helping guide them and coach them about how to do it. All right, school and work, man, college and work. Hopefully you all know some of these resources that are available as far as 504 plans for schools, and working if the kid's going off to college, working with the school and their disability center for accommodations. Most places are going to have standard letters, like and it could be around, you know, uh, uh, what is Crohn's disease? I have one for like in so there are some templates out there that you may be able to search for. But you really want to start the discussions early. Be practical about it. Don't hide it. Even when people do well, having a little insurance policy around this can be really helpful if needed. But the private room and bathrooms may be needed, may be a good option, testing accommodations. And then for people entering the workforce, thinking about these accommodations, IBD is a protected disability through the American Disabilities Act. All right, I have two more slides and then we got some time. Uh, drug approvals. This is more for it takes for like when somebody turns 18, it's like a magic box from when it comes to medication approvals. That's how the FDA treats this. And so there, this just kind of shows that it takes forever to get pediatric approval for these meds that you see on TV. Um, right, Rinvoq and Skyrizi are not FDA approved for people under 17, under or 17 and under. Um, really only infliximab and adalimumab are right now. Um, so that's a consideration. But when you turn 18, some of those prior approval processes and FDA approvals get easier. I feel this in my team has to do to get approvals. And so that is one thing as somebody goes from 17 to 18 that changes. And also some of these oral meds like Rinvoq, it's been on the market for 4 years. It's not FDA approved for kids. Your doctor will use them when needed for kids. But I think that's just important to know as some of the differences that happen as people get to adulthood. All right. I have